Welcome to Module 3, Stages of Wound Healing. Wound healing is not a single event. It's a complex, stepwise journey that unfolds in 4 distinct phases, each with specific cellular players and physiological goals. In this module, we'll explore the science behind how the body repairs tissue, and how you, as a nurse, can optimize each phase through skilled clinical practice. By the end of this module, you'll be able to describe the 4 phases of wound healing and their underlying biological mechanisms, identify the key cellular and molecular events at each stage, recognize the difference between normal and delayed healing using clinical indicators. Apply this knowledge to choose appropriate interventions and anticipate complications before they escalate, whether you're in acute care, rehab, or home health. Understanding wound healing at a cellular level empowers you to act decisively and advocate effectively. Wound healing is the body's natural restoration process, its way of sealing a breach and rebuilding lost integrity. But healing isn't guaranteed. Factors like infection, poor nutrition, or chronic disease can derail the process at any stage. That's why, as nurses, our role is to monitor progress, spot complications early, choose evidence-based interventions, communicate observations clearly with the care team. The wound healing process is classically divided into 4 overlapping phases. 1. Hemostasis. 2. Inflammation. 3. Proliferation. 4. Remodeling. Each phase builds on the last, and each provides a clinical window to guide our practice. Let's begin with Phase 1. Hemostasis. Let's begin with Phase 1, hemostasis, the body's immediate response to tissue injury. Timeline. This phase begins within seconds of injury and lasts from minutes to a few hours. Purpose. The goal here is simple but critical. Stop the bleeding and lay the groundwork for healing. Key processes include vasoconstriction of blood vessels to reduce blood loss, platelet activation and aggregation to form a temporary plug, fibrin clot formation, which creates a scaffold for incoming cells, release of growth factors like PDGF, TGF-beta, and EGF to signal the next wave of healing activity. Clinical relevance, you'll see visible signs, bleeding stops, and a clot or scab may form at the site. As a nurse, you should monitor for signs of abnormal bleeding or hematoma formation, which may indicate issues like coagulation disorders, anticoagulant use, or underlying trauma. This phase is short, but it sets the tone for everything that follows. Voiceover. Once bleeding is controlled, the body shifts into Phase 2. Inflammation, a defensive phase where cleanup begins and immune cells take the lead. Timeline. Inflammation typically starts within hours, peaks at 2 to 3 days, and can last up to a week in healthy acute wounds. Purpose? To remove bacteria, dead cells, and debris, and activate immune defenses. Key cellular players. Neutrophils, the first responders, killing bacteria and digesting debris. Macrophages, they clean up and release cytokines to promote the next phase. Mast cells, responsible for releasing histamine, which increases vessel permeability. Clinical signs: redness, erythema, swelling, edema, pain and warmth, low levels of clear exudate warning signs. If inflammation is prolonged or excessive, it may indicate infection, biofilm presence, or a foreign body. These should prompt immediate reassessment and intervention. As a nurse, your role is to support the inflammatory process while being vigilant for red flags that signal something has gone wrong. Once the wound is cleaned up, the body enters Phase 3, proliferation, the phase where rebuilding begins. Timeline. This phase typically starts around day 3 to 5 post-injury and can continue for 2 to 3 weeks, depending on the wound and the patient's health status. Purpose: to rebuild tissue, restore blood supply, and close the wound. Key processes include angiogenesis, the formation of new capillaries to bring oxygen and nutrients. Fibroblasts, proliferation, cells that lay down collagen and extracellular matrix, forming the scaffolding for new tissue. Granulation tissue formation, red bumpy tissue that signals healthy healing. Epithelialization, keratinocytes migrate from wound edges to cover the surface. Wound contraction, myofibroblasts pull the edges of the wound together. Nursing considerations, maintain a moist wound environment. This is crucial for keratinocyte migration. Avoid disrupting granulation tissue during dressing changes. Monitor for hypergranulation, an overgrowth of tissue that can impede epithelialization. This phase is where visible healing happens. Supporting it properly means setting the stage for durable wound closure. Finally, we reach phase 4, remodeling, also known as the maturation phase, the final stage of wound healing. Timeline. This phase begins around week 3 and can last for months to over a year, depending on wound size and patient health. Purpose: to strengthen and reorganize the newly formed tissue and build functional scar tissue. Key events include collagen remodeling. Type 3, collagen is replaced by type 1, which is stronger. Fiber alignment and cross-linking improves tensile strength. Capillary regression, the wound becomes less vascularized and paler. Scar formation, the endpoint of the repair process. Nursing considerations, educate patients on long-term scar care. Scars can continue to mature for months. Minimize tension on the healing area to prevent reopening or abnormal scarring. Monitor for hypertrophic or keloid scar formation, especially in patients with a history of such scars. Although the wound looks closed, healing is still ongoing beneath the surface. Re-injury during this stage can send the wound back to square one, so continued care is essential. Even when the body's healing system is ready to work, several internal and external factors can delay or derail wound healing. Let's explore some of the most common disruptors. Infection, bacterial contamination, especially biofilm formation, delays healing by sustaining inflammation and impairing granulation. Poor perfusion. Conditions like peripheral artery disease or excessive pressure reduce blood flow, meaning oxygen and nutrients can't reach the wound. Malnutrition. Low protein, vitamin C, zinc, or calorie intake can impair collagen synthesis and immune function, stalling repair. Diabetes. Alters macrophage function, slows collagen deposition, and makes wounds more prone to infection. Medications. Corticosteroids and chemotherapy can suppress immune response and slow tissue repair. Older adults experience slower healing due to reduced fibroblast activity and delayed angiogenesis. Smoking causes vasoconstriction and reduces oxygen delivery, directly impacting wound oxygenation. Repeated trauma or pressure can break down granulation tissue and reopen wounds, resetting the healing process. As nurses, we must be aware of these barriers, anticipate their impact, and plan interventions accordingly. Next, let's look at how to recognize whether a wound is healing or if it's stuck. Healing wound indicators. Wound size decreases each week. Red, healthy granulation tissue is present. Minimal to moderate exudate. Pain is gradually decreasing. Epithelial cells visibly migrating across the surface. Non-healing wound indicators. No change in wound size after 2 to 3 weeks of care. Granulation tissue is pale, fragile, or excessive. Heavy exudate foul odor or discolored drainage. Persistent or worsening pain. Rolled wound edges, epibole, undermining or stagnant epithelialization. These signs aren't just observations, they're diagnostic clues. They tell us when a wound is healing or when it's asking for help. So, how do we use all this knowledge in practice? Step 1. Match care to the phase. Each stage of healing has different needs. For example, hemostasis or inflammation. Use alginate or foam dressings to manage exudate. Proliferation. Support with hydrocolloids or moist dressings. Remodeling, reduce tension and protect fragile new tissue. Step 2, perform regular wound assessments. Document size, depth, exudate, granulation tissue, and edge condition consistently. Step 3, educate the patient. Guide them on nutrition, glucose control, hygiene, and smoking cessation. Healing doesn't happen in a vacuum, it's a team effort. Step 4, collaborate across the care team. Physicians, nutritionists, wound care specialists. Nurses are the bridge between disciplines. Step 5, speak the same language. Use phase-specific terminology and documentation. This improves communication, care planning, and outcomes. Wound healing isn't just a biological process, it's a clinical journey that demands knowledge, vigilance, and collaboration. And wound healing is not a passive process. It's dynamic, complex, and deeply influenced by the care we provide at every stage. Let's recap what you've learned. Hemostasis kicks off the repair, stopping bleeding and laying the foundation. Inflammation clears the wound of debris and sets the stage for growth. Proliferation builds new tissue, blood vessels, collagen, and epithelial layers. Remodeling strengthens the tissue, reshapes the scar, and finalizes healing. As a nurse, your understanding of these phases empowers you to detect complications early, choose appropriate dressings and therapies, educate and guide your patients through recovery, coordinate with your care team to ensure every wound gets the attention it needs. This is more than biology. It's precision nursing. Your assessments, your decisions, your interventions, they don't just treat wounds, they restore dignity, reduce pain, and transform outcomes. Thank you for your commitment to advancing wound care excellence. We're just getting started. See you in the next module.